In this episode, I would like to review a new paper in Nature Reviews Endocrinology that I think is really exciting, and it puts forth evidence in favor of using continuous glucose monitors for the more routine care of all people with type 2 diabetes, not just those using intensive insulin therapy. So the paper is from April 8th, 2024. And it's titled Continuous Glucose Monitoring for the Routine Care of Type 2 Diabetes. So right now, the standard of care it's only for the standard of care for type 1 diabetes or type 2 diabetes who are using intensive insulin use. That's the only people who are really the standard to use continuous glucose monitors with. Of course, way more people are using continuous glucose monitors for their health, to manage diabetes, and etc. But it's important for research like this so that we can create new standards. Why is that important? Because we want to increase insurance coverage and access for all patients. Because if you're in the know and you're working with a private pay provider, you will probably get access to this kind of care. But if not, you won't. So if you're a provider, I think this paper is worth a listen to keep you on the cutting edge of diabetes treatment. And if you're a patient, you'll want to listen because it will help you advocate for your needs, especially if you're newly diagnosed, but even if you've had diabetes for some time. So let's get into what this paper actually says. The authors of this paper, in their review, they point out that with current practice, diabetes is not managed appropriately. When it's not managed appropriately, which means in a timely manner, there are big increases in the risk of myocardial infarction or heart attacks, big risk increases of stroke and heart failure compared to those with type 2 diabetes who keep up on their treatment. And by treatment, I mean, in this case, they mean the use of medication that manages blood sugar levels. And keeping up on treatment in a timely manner means if your blood sugar goes too high, you address it immediately with a new medication or additional treatments to keep blood sugar down. And they conclude, as most people do, that early control of blood sugar is critical for minimizing long-term complications of type 2 diabetes. So in a nutshell, you want to catch type 2 diabetes early, get it controlled promptly, and keep it that way. But there are some reasons they pointed out for poor management, especially in the early stages. And they said there's a lot of non-adherence to treatment, and which means not taking your medication, not testing your blood sugar, not eating the right way, and therapeutic inertia, which delays treatment changes. So therapeutic inertia would be something like, let's say you had your blood test done in March and it showed you had a very elevated hemoglobin A1C, and you don't actually do anything about it until the next time you see your doctor the following March. And they said, hey, your last blood levels were high too. I think you have diabetes. Let's start looking into that. You've gone at least a whole year with diabetes without treating it. Or even if you just kind of go, oh God, diabetes, I don't know, and you wait like 6 months. So that's the inertia. Or if you are treating it and then your blood sugar goes up again and it's out of control, you again wait months or maybe a year before you make any modifications to your treatment plan. So these are the reasons that they cite for poor management, and those delays pose health risks for the patient. And let's face it, cost increases for payers. So insurance companies should care about this too, because they're just going to end up very expensive payments out for medical care that was preventable. And the authors find the self-monitoring blood glucose, i.e. finger sticks, to be cumbersome and ineffective. Not that they could be effective, but because it is cost effective and accurate, but it can be difficult to incorporate into daily life. So, imagine for every meal, maybe you've got to wait a set amount of time after eating to take your blood glucose, which means you need to wash your hands, get out your test strip, prick your finger, do the test and look at it, check it. And that's a lot of time. And you have to stop what you're doing. You might be at work, you might just be living your life, and you might just not want to poke yourself. So they're looking for an alternative that works better. Furthermore, and this is an interesting part, there's a lot of heterogeneity around type 2 diabetes. And what I mean by heterogeneity is that one person's type 2 diabetes isn't another person's. They have different causes, and because they have different causes, they have different solutions. And so, management practices, treatment options, treatment decisions should differ depending on what flavor you have. Some people have dawn phenomenon, some people have extreme blood sugar spikes or post-meal glucose excursions. Some people are more prone to hypoglycemia, more glycemic variability. I would add that, also the causes differ. Some people, it could be caused by a big contributor could be poor sleep apnea, medications that cause a rise in blood sugar. I see a lot, diet choices, stress, inflammation. So we need to look at all those. And the authors really suggest that the continuous glucose monitor is what can help us with this. So what the paper did, the authors they reviewed a number of publications, a number of studies. They looked at 12 randomized control trials, 4 retrospective studies, and a couple of interventional studies. And all the studies used either a Freestyle Libre or a Dexcom. And the studies went from 10 days of use to 2 years of use. And the outcomes these studies looked at were changes in hemoglobin A1C, which is that average blood sugar over 3 months. They looked at lifestyle changes that came from using a CGM versus finger sticks, the incidence of hypoglycemia, time in range, glycemic variability, hospital admissions, quality of life scores. So they looked at the comparisons between using continuous glucose monitors and finger sticks. And let's look at the recommendations. And for this, I'm going to share my screens for those of you on YouTube. And if you want to see this chart, you can just pop over to YouTube. Maybe I'll see if I can put this chart in the notes for you. So here are the recommendations on the screen share, and I'll just talk about them a little. First of all, for people who are on intensive insulin therapy, it's continuous access to continuous glucose monitor for daily use. That's what they recommend for that. But here's the interesting one that I think is great. At the time of diagnosis and early on in the disease, they recommend using continuous glucose monitors for 14 days after the diagnosis, routinely, to establish what they say your baseline glucometric profile, to help provide education on glycemic response to food. How does food affect your blood sugar, and how does exercise and other things, and to use this data to decide the initial treatment plan. This is so smart. And evaluate the patient's, early response to treatment. So if they do need treatment, get it in there in that 14 days and evaluate it. And then afterwards, after this onboarding period, then continuous access, basically access to CGM so they can use it about every 3 months, at least every 3 months. Pop a CGM on along with doing an A1C, like as another lab, so that can be reviewed by their doctors. And that's to reinforce their diet and lifestyle choices and inform medication changes. So these are their recommendations, and they make so much sense. Now, this is where I'd like to add my opinion on these recommendations, because in a nutshell, they are great, but I don't think they go quite far enough. But in fairness, they're taking that first essential step past what we're doing now based on what the peer-reviewed data says. The reason I think it doesn't go far enough is it still keeps to that medical management model of diabetes, which assumes it's a progressive disease managed primarily by medication and does little, I think, to empower patients to reverse the disease. Now, nutrition, dietary professionals, and health coaches, listen up here, because you are the ones that play the pivotal role here. But I'm also interested in talking to endocrinologists and GPs who can refer to these nutrition professionals and health coaches. Because with this continuous glucose monitor, I mean, this is super helpful and this will change a lot, just these recommendations. But with the CGM, we have so many more tools now to empower our patients to reduce their medication needs and improve glucose tolerance. And this works best when your patient has access to the CGM and the support and education from said nutrition professionals and health coaches to act on what they've learned. So, for this, and this is where I want to add on an idea, your patients need training. They need training like they have a new job, which they do. Their new job is to manage or reverse their diabetes. And I think, at least I find from my experience working this way, is that we need to treat our patients like a new hire and onboard them thoroughly so they have the skills to do their job well when unsupervised, when they're outside of the medical office, when they're outside of their appointment. And I find what works well to effectively create an entry-level diabetes expert, because that's what we're doing. And let me be clear, we can do this with anyone. We can make anybody an entry-level diabetes expert. And what works well for this is a better onboarding process that involves weekly visits. Telehealth works well, just a 20-minute telehealth visit during that first month after diagnosis using a CGM. So I repeat, what works well is a weekly review of CGM data and coaching for the first month. So that's more than just a 14-day period. Without this heavy onboarding process, most patients can be overwhelmed by the data and won't know what strategies to experiment with. It's kind of like a waste. I mean, you get some great data. Why just use it to manage medication? Why not use it? You can use it to reverse your disease or reduce medication use. It's this professional this professional contact plus nutrition education that's vital to giving our patients agency rather than leaving them feeling powerless in the medical management model that assumes that the disease is always progressive and it relies on increased dependence on medications. So it saves money in the long run too, for everybody. So I would agree 100% with this paper's recommendations, but I would add on the following modifications if it was up to me. For new users of a CGM with type 2 diabetes, they would need far more than 14 days to do their initial evaluation, but not a lot more and not at that much more expense. The first 14 days are absolutely needed to establish that glucometric profile and to help the user, the patient, start learning what diet and lifestyle strategies are helpful. That's part of it. But it does take really the first 14 days. This isn't really easy. It takes about 14 days to establish that profile. And the second 14-day period, and by the way, we talk about 14-day periods or 10-day periods because the Dexcom lasts for 10 days and then the Libre lasts for 14 days. So each one is a sensor that lasts for that long. So that's why so when I say 14-day period, if it's a Dexcom, just think 10. But the second 14-day period is usually helpful to continue this learning process of learning what's causing the high blood sugar, maybe what helps it. And this is where we start giving the patient some control. The patient can see how glucose levels can be managed, where some places can be easily managed through diet or walks after meals or meal timing, diet and lifestyle. And we can start seeing what's causing the rise in blood sugar. So we're looking at root causes and where they might need medication or supplements. So when they learn what factors are involved in their poor blood sugar control, like diet, exercise, sleep issues, stress, medication, inflammation, they also, and this is key, it gives them time to see how much progress that they can expect to make prior to medication. So we can get a new baseline. What can we do? What easy things can we do to control blood sugar before medication comes in? And depending on the contributing factors like sleep, inflammation, etc., it helps inform the choice of intervention. So if the patient will be on, okay, so let's back up a little bit. If you have someone with type 2 diabetes and they have sleep apnea that's undiagnosed and untreated, and you put them on diabetes medication, it's just going to continue getting worse. And that patient's going to feel like crap all the time. But if during this process of using a CGM and coaching your patient, you realize that their insulin resistance is linked to poor sleep, because signs and symptoms, you ask about their sleep, and you can see from the pattern of blood sugar that sleep could be a factor. That's when you would recommend a sleep study. That's when you would start putting effort. Sure, you're trying to control blood sugar, but you're putting just as much effort into trying to improve their sleep, which is going to be an independent risk factor for heart disease and improve their quality of life. So that's a key part to the second 14-day period of investigation. So in addition to you're starting to give that patient control so they can learn how to control their blood sugar better and get some agency, it's also helping the doctor, the health coach, the nutrition professional to figure out what some of the root causes are. And that's really important. And then if they need a medication to control blood sugar, or even have supplements like berberine, they tend to need a third 14-day period to evaluate its effectiveness. And this could be right away, or this could be like in a month or so. They'd want to bring the CGM on and bring the medication on to see how effective it is, if there's a risk of causing hypoglycemia. Because even if you don't go with the medication, you go with something like berberine. Berberine, if it's misused, can cause hypoglycemia. If you take it at night and have a few glasses of wine, that person could have overnight low blood sugar. So there's still an important learning process to go through with that. And that's where another CGM is used for. So in a nutshell, doing an extended period, the first 14 days to establish the glucometric profile, the second 14 days is a learning process to try to understand underlying causes, and to give the patient a little more control to see how they can control it on their own. And then a third period at some point to help evaluate medication. And every time you bring on a new supplement or medication to evaluate its effectiveness, you're going to give a better chance of improving their blood sugar on their own, making smarter medication choices, and other benefits. For example, improving their sleep, or if there's underlying inflammation, dealing with infections, or possibly medications that could be causing high blood sugar and switching that. So it just makes a smarter process and a much more whole person approach to managing type 2 diabetes. You're supporting the person, not just type 2 diabetes. So finally, after this big onboarding process, then I agree, proceed to using intermittently the CGM about every 3 months as another lab. They go in, they get their A1C done, put a CGM on for another 2 weeks or 10 days and see how things are going. Is their current diet appropriate? And is their medication working? And that's as an opportunity for further education, a little accountability, to remind them, this is part of accountability, reminding them that, oh yeah, that's right. Oh boy, those candy bars were starting to creep in. They were once a week. Now they're 4 times a week. So it's a nice reset every 3 months. So what's important is this: publications like this will lead to the use of continuous glucose monitors as a standard of care for type 2 diabetes with or without intensive insulin therapy, and therefore get insurance to pay for it. And this is important for increasing access. And a paper like this will lead, and I think this will happen in 10 to 20 years. Why? You might have heard that it takes on the average 17 years for research like this to become standard of care. But as a listener, especially if you're a provider, you have a chance to get ahead of the game and really help your patients, because helping your patient now versus waiting 17 years can make the difference between them dying at 55 or living until 80 and living well. However, the lack of insurance coverage really should not stop you from prescribing or using CGM for these purposes. Remember, each one of these 14-day CGMs will cost you around $40. I personally just paid $78 for 2 Libre 3 sensors at my pharmacy today. And depending on the brand you use, the manufacturers, they have programs which will help you, will help regular users always get the lowest price consistently. So, work with your providers and your pharmacist to find this out because it can make the price of long-term intermittent CGM use competitive with using test strips. So it makes it affordable even without insurance. Besides, you get better data and better control of your glucose. So if you're a dietitian, nutrition professional, health coach, you can use this research to encourage your patients' prescribers to follow this strategy so you can then be the educator and the coach for your patients on how to use their CGM data effectively to improve blood sugar control, reduce medication needs, and improve their quality of life. If you're a prescriber, you can simply follow this strategy and collaborate with and refer to nutrition professionals and health coaches who can support your patients and do this onboarding process for you, because that's not usually a doctor's job. So again, this paper is titled Continuous Glucose Monitoring for the Routine Care of Type 2 Diabetes. And it is in Nature Reviews Endocrinology, April 8th, 2024, by Ajjan et al., spelled Ajjan. And I'll try to put a link to that in the show notes. So I hope this commentary and review was helpful for you, and thank you so much for listening.